I must admit, when I first started, I was really excited about giving this talk. And then when I started putting it together, I quickly became overwhelmed. So you probably are going to see this because what I wanted to do is give a broad overview of what's going on and give you sort of an understanding of what's happening. And it's impossible for me to go really into depth of everything. So the first thing is my disclosures. The first thing I'd like to disclose is I will be talking about a procedure which is actually experimental, and I'm part of the investigator group, and I will tell you when it is either experimental and what's going on. I have tried to stay unbiased, and I will try and tell you when I am biased, maybe a little bit, and when I'm not. The other thing you need to know about me is I'm a huge proponent of conservative management. Anybody who knows me knows I've been pushing pessaries and conservative management for years and years and years. Having said that, I think what's even more important to me is to make sure that women actually have the right to choose the therapy they want to have. And to do that, the only way we can begin that discussion is if we give them appropriate information so they can make the choices that they feel is appropriate for them. And therefore, this talk is actually important because you need to know about surgery. You need to know some things about surgery, what's going to be available for women so that they can make the choice that they feel is most appropriate for them at this time. The other thing is a disclosure is that I actually love living in Calgary, and for those of you who are not here, I hope you do enjoy a little bit of the outdoors, even if it's going to be raining all weekend. So going on for this, the objectives of this talk was first of all to distinguish and to talk about the surgeries that are available for urinary incontinence. With that, to appreciate what the outcomes are, as well as the complications related to surgery, and to be able to actually begin at least a preliminary discussion with women presenting with you with urinary incontinence about what some of our options may be. Now, when I talk about urinary incontinence, oftentimes when we're coming about surgery, we're only thinking about stress urinary incontinence. But I'd like to talk as well about what's available surgically for overactive bladder and actually urinary retention. So we're going to do the whole span of everything. So let's begin with urinary incontinence. So the way we always think of urinary incontinence is loss of the support in the back of the vagina. And this is what we do with conservative management, doing pelvic floor exercises. Let's get that support. With pessaries, that's where they're fitting. We're in the back of the anterior vagina, giving that support. And traditionally, that's how we always think of stress incontinence. And it's a nice way of thinking of stress incontinence, sort of like prolapse. You've lost the support. And what we're going to try and do is rebuild that support. But stress urinary incontinence actually has a second part to it. And we cannot forget that there's an intrinsic sphincter. Let's call it like a valve around the urethra from the UV junction about to the mid-urethra. And that's going to give you some extra squeeze. And if you lose that intrinsic sphincter function, you are going to leak. And likely the women who present with urinary stress incontinence probably have some kind of combination of the two. And maybe that's why we don't see the success rates that we would like to see at 100%, because there's always a combination of the two. And so when we're going to be talking about surgery, let's see how we can address potentially these two aspects. So most of our surgery, like I said, for stress urinary incontinence, is trying to give that support in the posterior aspect of the vagina so that women don't leak. The same idea between using incontinence pessaries. And we look at the surgeries that are available for us, and what we're going to talk about today is a tension-free vaginal tape procedure. Some people call it a retropubic vaginal tape. We're going to talk about a transobturator tape. We're going to talk about mini slings, Birch retropubic urethropexies, pubovaginal slings, and I am only going to mention anterior pairs or Kelly plication to tell you they should not be done. Okay? They're an ancient surgery with poor results and should be off the list for urinary incontinence. Now, let's go TVT, TOT, because everybody talks about them. So a tension-free vaginal tape procedure and a transobturator tape. So you're lucky today because it's going to be a bit of show and tell as well. So what do we do surgically when we do a TVT? So what you've got to recognize for now is our TVTs are considered the gold standard surgery. In other words, it's a surgery that all other surgeries seem to be compared about, and certainly has not yet been dethroned. With this as well, the TOT, and there's a bit of controversy there, but most people will go for the TVT as a gold standard surgery. So what do we do in the operating room? We make a little incision at the mid-urethral level. So remember, the urethra is 4 centimeters long, so about 2 centimeters. Some people will start about 1 centimeter from the meatus and do a 1 centimeter incision. And then we're going to dissect sort of around the urethra, and we're going to bring the tape up to the top of the pubic bone. So one of the things we do, and I've got them here, and this is the samples I had in my office, and this is the Boston Scientific, but the idea is sort of the same. You have these big wonking trocars, okay? We make the incision underneath the urethra, and now what we're going to do is we're going to bring it above, up to the pubic bone and out to the side. And then we're going to take it out and we're going to do it on the other side. So what's going to happen is if we take this trocar out afterwards, our mesh is going to stay underneath the urethra and come out above the pubic bone like this. And this is our incontinence procedure. That's a TVT. Our TOTs are done slightly differently. Same mesh. But with the TOT, we have other needles that we take, and we bring it through the obturator foramina, through the obturator fossa. And we're going to come in, make a little incision in the groin, okay, just lateral to the clitoris, and we're going to take our tape, and we're going to bring it out underneath the urethra. And then we have one for the other side, so these come with 2 trocars, one for each side, and we're going to do the same thing on the other side. So the difference is going to be that when we have our TOT tape, it's going to come out through here, okay, this way. And so it's going to cause like a little hammock underneath the urethra through here, while our TVT comes out suprapubically. So one way to think about it is that a TVT is often thought of as a U underneath the urethra, and a TOT as a V. It goes out more laterally. The advantage to these surgeries, well, advantages, we won't say yet an advantage necessarily, is we do use synthetic meshes. And we're going to talk about those in a minute. It can be done as an outpatient surgery. So women come in on the day of the surgery, they go home the same day. So we do them as outpatient surgeries. It can be done under local anesthetic. It can be done under general anesthetic. We can do a spinal anesthetic, although we don't tend to use that. Women have minimal pain. So I'll have a woman use a narcotic maybe 1 day, 2 days. A lot of women just going home on just plain acetaminophen and ibuprofen. They're driving within about 3 or 4 days. They're back at work quickly. I do hold back some of the activity they're doing. So to me, it's no heavy lifting, no pushing, no straining till everything scars into position, and nothing in the vagina, except for estrogen if they're on it. But it's not without its controversy, and we'll talk a little bit about what that means. So the question then becomes, and this is where we've got to be careful when we discuss results. It's really frustrating to read the literature because you can always find what you want to justify what you want to justify. And the literature is plagued with results from TVT and TOT, and trying to wage your way through it is almost impossible because every study can be criticized, every review can be criticized, and it goes on and on. But if we look at sort of general results, and what I did here is I took a meta-analysis that was done, and I tried to use the one that was the most up-to-date that I could find. And what they did is when they compared TVT to TOT, it seemed that at a long or medium term, which means anywhere between 1 and 5 year follow-up, objectively, more women appeared to be dry with a TVT than a TOT. TVT being slightly better. But what I want you to look at when you look at, and you've got to be critical of the literature, is if you look at the odds ratio, the upper limit of it is, can you see it at 0.99? If it was 1.0, it would be non-significant. So it's just made it. It just squeezed in this meta-analysis. And if we look at subjective cure rates, they actually come out to be similar. so no difference. Now, what I did is we did a study here in Calgary, and we have our 5-year outcomes. And so for us, what's advantage to that is that we know within our surgical hands, what do we do? I don't really matters what they're doing in Finland and in the Netherlands. What are we doing in Calgary? And our 5-year outcomes essentially were the same. So even though here it appears that TOT is better, that was non-significant. So essentially our subjective cure rates were the same, our objective cure rates were the same. And it was very difficult to find what is a cure rate. So what you can see from our 5 years out of surgery, we can quote a general cure rate of women objectively not leaking at about 80%. So 80% of women will be dry by 5 years following surgery. And subjectively, that goes up to over 90% will say they are very dry and they're happy at 5 years. That's pretty good. Now, some of the controversy gets around where people then try to dissect types of incontinence. In other words, why don't we have a 100% cure rate? We want 100%. And are there subgroups of women who are more likely to fail? We know women that are obese are more likely to fail surgery. They're likely to fail everything, actually, which is unfortunate. And so people have looked at that a little bit and said, yes, they do fail more. But the other thing is, remember I talked about that extra squeeze you have around that intrinsic sphincter. So how about those women where it appears they're weak? And how you define intrinsic sphincter is a whole talk in of itself. But essentially think of women who don't have a lot of squeeze. We're not talking pelvic floor. We're talking a different intrinsic sphincter that's by the autonomic system, so we have less control over it. Well, when we start to look at those, and we look at TVT versus TOT, this subgroup of women, and they're usually the heavy leakers, what we find is that actually subjectively, TVT appears to be doing better than TOT. And maybe it's because of its position. It's more, let's call it obstructive than TOT. But again, objective cure rates, we don't see that much difference. In complication rates, not that much difference. And if we look at reoperation rate, which is something that we often look at about how many women are going to another procedure or getting something done, some kind of revision or that, we find that the TOT rate is much higher. So potentially TVT may have a slight advantage over TOT. How about complication rates? Complication rates, we worry about erosions, and we're going to talk about mesh in a minute. What do I mean by erosions? You can see in the picture here that if it does not heal well in the vagina, then the mesh is going to be sticking in the vagina, and that can be a problem, especially if women are sexually active. It doesn't feel pleasant. It's irritating to have it there. You're not going to get an infection normally, although it does happen rarely, but erosions are things we don't like. When we look at the complication rate, it's slightly higher in the TOT than the TVT, but it doesn't really reach significance either, and this is all over the literature. Now, bladder perforation is something physicians love to talk about, and of course it's higher in TVT than TOT. It's inherent in how we do the surgery. The bladder is sitting here. I'm taking a trocar that you could, do a shish kebab on, and I'm just blindly bringing it over the pubic bone. Of course, at times I'm going to hit the bladder. Now, the way I look at life, though, is what is the consequence of hitting the bladder? We always do a cystoscopy. Leaving a piece of mesh in the bladder, not appropriate, okay? And that's unacceptable. But if we do see it, what do? We take out the trocar and we go for it again. Not for the bladder, I mean for the position, okay? And we put it back into position. We leave a catheter in the bladder for 2 or 3 days, let the bladder heal, and on we go. So to me, I think of it as more of a bummer than a complication. It's inherent in the surgery that we do because we have to hit the bladder occasionally. It has to. But long term, are there any implications? No, as long as we pick it up. And the way I like to think about it, and I don't know if in your centers, we don't do it so much in Calgary, but suprapubic catheters in some centers are still used routinely. And I can remember as a resident, my job was to go around post-op and yank out all those catheters. And what did we do? We just said, take a breath in, pull out the catheter, put a piece of gauze, and walked away. And now is there a hole in the bladder? and nothing happened, and we didn't worry about it. These holes are actually smaller than that. And so this is one thing we need to say as we keep talking about bladder perforations. To me, it's just a hiccup in a surgery where it's inherently going to happen. In this case, 2.5% of the time, which is not really that high. I don't want my patients to have long-term pain. Postoperative pain I can accept, but long-term, when we look at it, TOT is significantly higher than TVT. Now, the numbers are not huge. We're talking 6% and 2%, but still, that can make a difference in a surgery you choose because you have to deal with pain after that, and how are we going to treat women with pain. The next thing is, as you know, as soon as we start obstructing, voiding, we're going to start to have voiding dysfunction. And what is that going to be? We know all of our surgeries can give us overactive bladder symptoms. And what is the rate? Well, we find that maybe when we look at overactive bladder symptoms, it's no different between TVT and TOT. Running around 10% of women are going to go into surgery without overactive bladder symptoms and walk out with them. And so that's part of the informed consent that may happen. And this is more of a long term. This is not just a day or two after surgery. And then the other one we worry about is urinary retention. Again, long term. What does it mean for women? Because they may need long-term catheterization. And that risk is actually non-significant between the two, running at about 5%. In our center, we actually run lower than that. So I will quote in women having a TVT, just to make numbers, 80% success rate is what I quote them. I quote them an erosion rate of around 3%, that they may need another procedure to take care of it. I'll quote them actually, and I'm a bit negative on this, a 15% chance of overactive bladder, and maybe I should drop it to 10% after I've given this talk. And I'll give them about a 3% chance of having incomplete bladder emptying requiring catheterization. And at that point, we get into other management options. If they're not emptying well, we lyse the meshes, we take out the meshes, they're catheterizing, and we move on from that. So it becomes much more invasive. So even though the risks, if you think about them, are quite low, they're not zero. And that's a part we need to appreciate. Very high success rates, but there's also complications associated with it. Certainly, all surgeries are associated with risks of death, and they have been reported in both TOT, TVT, but they've also been talked about when, ingrown toenails, you can die, and anything we do, we can, kill people. And the way I look at it is I also tell women, yes, but if you leak and you slip on the floor, you could die of a subdural hematoma, and we don't count those. So how do you know? And we need to put it all into perspective when we talk about surgery. So what happened is because of this erosion rate and voiding dysfunction, mini slings were invented. And what are mini slings? Really, they're touted as being less mesh. So they essentially are a little bit like TOTs, except they don't come out. We tack them, if you want to say, to the obturator fascia that's over the obturator foramen. So we tack them with anchors inside. So they're said to be less mesh, because now you only have this much mesh versus this much mesh for a TOT and about this much mesh for a TVT. But remember, the erosions are usually underneath the urethra, so it's still right there, okay? They're talked about being single incision. So single incision versus a same incision and two little stab incisions in front of the pubic bone. They're talked about being less invasive, and because of that, we'll have less complications. But what does the literature tell you about these mini slings? Well, when we look at the meta-analysis, it seems that TOTs and TVTs certainly do better than mini slings overall. And so although some centers are certainly still using mini slings, a lot of centers will just do TOTs and TVTs. Rates of pain, rates of voiding dysfunction, rates of erosion are exactly the same. So if you're going to have a lower cure rate, potentially I'll go for a TVT personally. But again, like I said, that's a personal bias. Now the big problem, as you've all known, is all these controversies about permanent mesh, and what are they about? So what happened in 2011 is the FDA issued a warning, And it said that vaginal mesh complications were not rare, and this was an area of concern. Well, you can imagine what the next fallout to this was, and that is by early 2015, over 70,000 women in the US had filed lawsuits against the companies who marketed these meshes. Now, they were marketing them and they were filing lawsuits because of erosion, injury, and pain. Now, the problem with lawsuits is that they're a big industry. And you have lawyers touting, and if you followed, and we have a CIHR grant looking at the evolution of what's been going on with TVTs over the years. And it's very interesting to look at these lawsuits and see what happens in the advertisements and people actively chasing women who've had incontinence procedures. And unfortunately, many of these women are of low socioeconomic class, and telling them they'll get money if they go and see a specific physician, and they'll fly them out to have surgery, and that's a complication, and we got a lawsuit. So where in that spectrum are these women who'd had complications who may have been able to be managed quite easily with conservative management, and how many of them actually had problems related to the slings, we don't know. Erosions, yes, they're easy to identify in that. But let me give you an example. So all vaginal meshes were sued. Okay, so back to show and tell. Here's your TVT mesh or your TOT mesh. If you want a mini sling, let's cut it to about this. This is your incontinence procedure. This is what we were putting in. I think you can appreciate the difference between lumping everybody together between an incontinence procedure and a vaginal mesh. It's very difficult. So the outcome to these lawsuits were that all these products came off the market. This no longer exists. I'm keeping it because I think, we could start a museum or some sort of, profit, eBay, I'm not sure yet. But they're off the market, and you don't see them anymore. And companies went under, and probably the biggest company that I've seen recently that's gone under is AMS. And I shouldn't say under because I'm sure the wording is inappropriate, but they're not in the incontinence business anymore, or the prolapse business. They've come out. And we've just seen all these companies fold, which is, in some ways, I think it's a good thing, because what it's done is it's forced us to have to allow research to give us the information we need to know whether these products are safe and what their outcomes are before they start to hit women. And I think that is appropriate. But the other thing it's done is it's scared women. And a lot of that is misinformation. So that's where we are. Now, what I've noticed, certainly in Calgary, is now things have died down and women are a bit more relaxed about it. But we used to have extra clinics on everybody we'd operated on to reassure them they're fine or not to, as well as people who'd never had mesh who thought they may have. And I think every center had that happen to them as well. So what it's done as well, and it never completely went away, is a Birch retropubic urethropexy. Now, this is a surgery that was, let's say, invented around the 1950s. Okay, it's been around forever, making a resurgence, and certainly in some centers has never actually gone away when TVT came in. And what is it? It's slightly different. So what we do, if I can find my pelvis again, is it can be done laparoscopically, or it can be done by laparotomy. We go into abdominally, so we go from above, bring down the bladder where it's a bit plastered against the pubic bone. It sits there nicely. We can bring it down. It's quite easy. The planes are there. And think of the bladder, I always think of the bladder as being kind of lazy. It's not a bladder problem. It's a vaginal support problem for incontinence. The bladder just rests on the anterior vagina. So it's not the bladder we want to pull up. It's the anterior vagina we want to support underneath the pubic bone. So in a Birch retropubic urethropexy, you think of the urethra, and this is my bladder, okay? And I've got the vagina sitting here. I'm going to put sutures, because I've dissected down, right where the urethra and the bladder meet, the UV junction, and I'm going to put permanent sutures through the vagina there, and usually they're permanent, but there's also a tiny bit of controversy for that. And what I'm going to do with those sutures is now on the pelvic rim right along here is Cooper's ligament, and it's got some fascial tissue there, and I'm going to put my sutures there, and I'm going to bring up the vaginal wall. So if you think about it, it does look a little bit like a TVT, but a little bit different, but same kind of general idea. Let's give that support, let's bring it up, and we're bringing it anteriorly. Now, what are the success rates? Well, it depends on who you want to see and what you want to read, but the problem is this surgery's been around for a long time, so most of the studies have been done 20 years ago. And is that comparative to today, considering that now we do research a little bit more rigorously? So success rates run somewhere between 55 and 70%, and this was a review that said that. But there's another, they say, are comparable to mid-urethral slings. So oftentimes people will say there's no difference in outcome between birches and TVTs and TOTs. And that's difficult to know because another meta-analysis actually favored TVT over the birch retropubic urethropexy, this time with an odds ratio of 0.61, a little bit further away, as you can see, it's not 0.99 like it was with TOT, it's 0.82, so that looks pretty good. And the objective cure rate also appeared to be better, favoring TVT. So it does appear that likely TVTs are better than birch retropubic urethropexy, with the birch having the advantage, though, of not being a mesh, but having the disadvantage of being certainly more invasive than a TVT. And when we look at voiding dysfunction, maybe a little bit less in the birch, but that's hard to know, but complication rates being similar. Now what's interesting is, remember the mesh complications complained about pain as a reason for litigation, but when we look at pain of a birch versus a TVT, exactly the same. So they're not higher rates of pain. So then comes an old procedure as well, pubovaginal slings. People stopped using them when TVTs came out, okay? But there's a room for them, and I know centers are still using them. And what are they? Think of the mishmash of everything together, and you've got a pubovaginal sling, okay? So it's a combined procedure. You have to go vaginal, and you have to go abdominal. What you're doing with the sling is you're making an incision underneath the vagina. Again, see, that's the vaginal part. We're going to put some sling material. Let's use a mesh here just for example. And we're going to bring it up, essentially, as you can see, almost like, exactly like a TVT. Except remember, TVT stands for tension-free, because a TVT, we just cut the ends and there it is. But with a sling, what we're going to do is we're going to tack it up to Cooper's ligament like we did with the birch. So it's fixed. Okay? So if you want to say it's a combination almost between a birch procedure and a TVT. So let's take the best of both worlds. In terms of location, so we said if you want to say the TVT is like a U underneath the urethra, the TOT is like a V, and a pubovaginal sling is somewhere in between, okay? People who can't really know between the U and a V, so a U.5, I don't know, something like that, okay? Now, what you can do with the pubovaginal sling, which makes it slightly interesting, is what do you put underneath is your choice. So you can use a permanent mesh, okay, and that's certainly been done, or people use fascia. So if I'm going to do a laparotomy, let's say, and so open the woman, I'm going to take a little bit of her abdominal wall, the fascia there, and I'm going to use that to do my sling. So now I'm using her own tissues. Or you can actually go in and get the tensor fascia lata on the side by a separate incision and use that. So now mesh erosions are no longer an issue, and we don't worry about it. Now, what's come along, and they're trying to make a resurgence poorly, and it's the kind of thing that we have out there looking for an indication, is we do have what I'll call here biomesh, okay? And these are porcine intestinal mucosa, things that we say, okay, are not like permanent meshes, but they'll give the architecture or the ability for our own tissues then grow in. They'll chomp away at this business because that's what our body does. And then we'll be left with our own, if you want to say, mesh in place. But unfortunately for incontinence, they've had really poor outcomes. So we don't use them. Okay, so if you start to hear about biologicals, we don't see them, okay, because they fail. So let's shift gears a little bit, okay, and then don't worry, I'll be summarizing it soon. We talked about the ISD, about the sphincter. Can we do anything about it? Well, yes, we can. We can plump it up. Okay, so think about it. I tell women, it's a little bit like, caulking your tap because it's leaking. That's what we're going to do. So the people who are really good for this kind of caulking, and we'll see why in a second, are those people with ISD. So usually, let's say I've operated on a woman, and my TVT, because that's the one I do like to use, and here's a bias, and I did a terrific job this day, okay, and the TVT's in a perfect position. The urethra now is not moving, and she's still leaking. What am I going to do with her? Well, if I did a lousy job, I could do it again. But there's no use doing it again if I've done a good job. So I'm going to go in and caulk her. Okay, I'll do the bulking and say maybe it's an ISD problem and I need to do that. So women with what we call the fixed urethras or the ISD may be very good candidates. Sometimes we'll use women who are such poor surgical risks, we'll give it a try. And young women, because we don't want to be putting permanent meshes or operating around the urethra, if these women are going to go on and have vaginal deliveries or go on and have pregnancies in the future, because we don't want them wrecking our surgeries, because your first surgery is always going to be your most successful surgery. So that's important. So the advantages, so let's talk about the advantages first. It's an outpatient procedure. We can do it in the office. Okay. They complain of 24 hours of burning when they pee, but then it usually goes away and off you go. You can resume your activities as soon as you get off the table. You want to go for a jog? Go for it. So there's no pulling back of activities after that. And the complication rates are actually very low, where urinary retention is 0.4% compared to, let's say, TVT, which was, I quoted at 5%, and I say usually 3%. So much lower. There are some disadvantages. Success rates are low. Okay, 42% cure at 1 year, not brilliant. So the reoperation rate is high. So what I quote for women is I tell them, after 2 injections, you have a 50% chance of being dry. Okay, not great, but if you're wet all the time and you don't have that many options, that may appear attractive to you. The other thing that's hard is the costs of it, and I actually did ask outside the cost. 1 injection comes out to about $1,700. That's just for the gizmo. We're not talking anything else beyond that. So we're talking about $3,500 for a 50% chance of being dry. It's expensive, which is why most hospitals don't like to cover it. Now, what I didn't tell you about is what we can inject, and people have injected everything, okay? In the past, they've even injected Teflon, but what have we tried? So we did studies in Calgary looking at stem cell research where we took muscle biopsies and plumped it around. Sounds really intelligent. Success rates were 50%. Yay, you know? People have tried fat. People have tried cartilage, taking it from the ear. People have tried these micro beads and all sorts of things. So the product we certainly use in Calgary is the one that's outside, which is Bulkamid, which is hyaluronic acid derivative. And one of the reasons we chose that is because it's exactly the same stuff that all those movie stars are using to plump up their lips. So this is how I tell it to patients. You're not getting it in your lips, you're getting it around your urethra. Okay? And as you know, those movie stars, they do keep going and getting it redone. And not so they start to look like really a blowfish, but really because it starts to dissipate. And this is the same thing we're seeing, which is why you do need touch-ups. and why women should not think it's just a one-off. Now, the problem with it as well is there's not really that many really good studies on bulking agents. So let's summarize stress incontinence. And this is a really difficult slide to make. And I do want you to take it with a little bit of a grain of salt, because depending on who is giving your talk, they may change the order a little bit. So I'll try and be honest. If we look at all the incontinence procedures that are out there, what are the success rates? Who's the best? Well, most people will still consider the TVT the gold standard surgery. Pupil vaginal slings, though, seem to come out the same, but the studies aren't great comparing the two. TOT comes in maybe very close second, and you could argue they're the same. And the Birch retropubic urethropexy coming in right behind. And the reason I highlighted those in red is that you could probably successfully argue that they're all equivalent. But I thought what you needed to do is get at least some way of knowing what's going on. But they're very, very close. And you could easily argue, depending on which study you want to quote, that it's not true. But it seems to be a trend that we're seeing. Many slings seem to be doing worse. So they're coming behind those 4 surgeries. And bulking agents way behind. So here's something that's easy to remember for me. TVT 80%, Birch RPU 70%, bulking agents 50%. And that's sort of me in easy numbers to kind of remember, to give you an idea of where these things are falling in. With pubovaginal slings and TOTs, you could probably throw them in around 80% as well. And I tend to want to prefer to be pessimistic than tell women 90% of women are very happy with surgery. I prefer to be negative when I consent for surgery. If we look at the complications, and to me the complications are important when they're long-term complications. The short-term we can usually deal with quite well unless it's death, but usually women will recover well from short-term complications. So what are the long-term complications? What I worry about is voiding dysfunction, so overactive bladder symptoms. Who has the highest rates? Pubovaginal slings, followed by TVT, followed by TOT, although oftentimes TVT and TOTs are very hard to separate. Birch seems to have less voiding dysfunction, and bulking agents really don't, but then that's, like I say, its own set of problems. So pubovaginal slings, most invasive. TVT, TOT coming about the same. Birch is a little bit better, so maybe that's going to change how you choose to do your surgeries. In the pain, I couldn't really find a lot of pain literature, and that really bothered me because to me that's an important outcome long term. It appears that the outcomes from TOT, you have more pain than with TVT, and that includes groin pain mainly. Now I have to say from our 5-year study, we didn't see that difference, even though I was a bit biased, hoping that that would be what we said, but we actually noticed no difference between the two groups. But in the literature, TOT seems to show more pain, but I think maybe that pain is more short-lived than we think it is, and that by 5 years, there's really no difference. And the erosion rates, running anywhere between 3 and 5%, any procedure we do has that as a risk. Okay, but the risk of erosions, if it's in the bladder, not good. If it's in the urethra, a nightmare. If we put it through the bowel, heaven forbid. But if it's in the vagina, usually we can deal with it. Okay, it doesn't mean the woman needs to come back, but usually we can deal with it. So what's out there? I'm going to call it vaginal laser rejuvenation. So this is out there, and it's really right now a little bit in the cosmetic industry, but it's starting to become more mainline, and we're starting to see it move, okay? And I think you need to be aware of it. What is it? There's 2 types of lasers right now that are being used for your vagina. That's an ergon YAG laser or a CO2 laser, and I'm not going to debate what may be the advantages and disadvantages of the both of them, okay, but they're the 2 of them out there. How do they work? They're essentially causing focal burns in the vagina, and as soon as you get those focal burns, what are you going to get? you're going to get scarring, but let's rephrase scarring, okay, for now, because scarring has a really negative connotation, and here we're going to be slightly optimistic, okay? As soon as you get any kind of injury, you're going to get cellular degradation. After that, you're going to get collagen and cellular formation, and then you get remodeling. As this happens as well, you will get a microvascular infiltration coming in to try and help heal these things, okay? And the idea then is that the result of these microabrasions is you're going to get tightening of the vagina. Now, what does that mean? So you just go in, get a probe, put in your vagina, get it zapped, relatively painless, and off you go and let the remodeling start to happen. If you can target some of that underneath the urethra and the anterior vagina, is that going to tighten up enough for you to be dry? So I'm not going to talk about the cosmetic aspects about having, the joys of a tight vagina. The only thing that I find interesting to me, because I'm looking at a medical perspective, is that it appears to be interesting to me from a vaginal atrophy perspective that women are saying that they have more vaginal discharge. So here we are talking, and there's a lot of other boosts out there, and I'm not going to downplay their importance, is we have a lot of women who don't want vaginal estrogen. Then we start to put them on the non-estrogen moisturizers, and they have their own set of advantage, and they have costs associated with them. Well, if I was really dry and I could get my vagina, let's say, lasered, and all of a sudden I have nice, beautiful discharge and I don't feel so dry and irritated, well, that might be attractive. And to me, that's where I find it exciting, is this is a huge problem for pessary use. And is this something that's interesting? I find it interesting, but I'm just throwing it out there, okay? Because what does it mean? Now, it's really difficult to look at the literature, and I want you to be very critical about it, okay? Because when I went to see actually what was published, and I don't want to see abstracts, I want to see published papers, it's very difficult. But I did come across this paper. That's 3 treatments. So recognize you're not going to be dry after 1 treatment. You need at least 3 treatments, usually 2 months apart. And this is done with a YAG laser, okay, that they reported 62% of their women were dry at 1 year. Now, this is probably a procedure that's going to need to be repeated. Again, you're going to need touch-ups for it. We don't know what the outcomes are. I think it's too early to say what really is going to happen. Is YAG going to be better than CO2? CO2 better than YAG? I think what you're going to find is this fight's going to go on with advantages and disadvantages. But what I really want to know is what is actually the outcome. So you need to know about it, because I've certainly had patients come in and talk to me about it. And you need to know what's out there and what's available, and that this may be coming down the road and may be an alternative for women who don't want something aggressive done to them, like a procedure, don't like the idea of pessaries, and it's an opportunity. It is not covered. So it is done privately, and the cost is going to be close to $3,000. I think that's about an appropriate kind of cost, and that people are saying, and that often is a combination of all treatments, so 3 treatments. I'm not talking per treatment. Who knows? What happens when you zap? Theoretically, you should, if the mesh is not eroded, because the depth of penetration of the lasers is actually very low. Okay, so theoretically, it's only going at the dermal layer. So if your vagina is nicely healed, theoretically you should, but there certainly is no studies out there to show that yet.
The other question might be, what would be the implications of having that done before you wanted to have surgery?
No clue. We don't even know what the outcomes are on preliminary. Exactly. Yeah. Now, this is not radiation. Yeah, so it's...
Kind of analogy
it's not quite so aggressive. Where the technology comes from is from laser rejuvenation. So, people are getting it done to their faces all the time, and you look so young, so it's kind of interesting that everything you do to your face, you seem to be doing to your vagina, right? And I'm going to leave that one alone. I put this slide in because I find it really neat. I like it when people start to think a little bit outside the box and to say, well, what else could we be doing? Rather than reinventing what we're doing and try to do it better all the time, can we do a different approach and see what's going on? So this is a new, let's call it technology, that is not on the market. It's still patent pending when I tried to Google it. And I like to call it, the princess and the pea, and I thought that pun was hilarious at the time. Maybe it was late at night. But the idea is that you leak because you increase abdominal pressure. You're coughing on your bladder. Well, that's all transmitting down to your bladder trigone area, and you're leaking because you've lost the support. Well, what if we decrease that pressure so you can cough, you can vomit as hard as you want, but your bladder doesn't know what's going on? And how can you do that? Let's put a cushion. Let's put a cushion between your abdomen and the urine in your bladder, so the pressures, it's almost more now like jumping on a trampoline. It's nice and gentle. And that's what they've done. They've made these little balloons, and you've got the picture there. You stick it in the bladder, and it's your little mattress for your bladder. You can do that, and then after a year, though, it does need to come out, and you just slip in another one. So it could be done easily in the office. The preliminary reports show 43% reduction of leakages. Sounds exciting, but I don't know about you, but my patients don't like reduction of leakage often. They want to be dry. So I don't know where this is going to go. It's quite preliminary, but I think it's kind of fun, and it's something maybe to look out for and see what's going to happen. But things like bladder infection rates haven't gone up. Overactive bladder symptoms didn't go up, and maybe it's because it's small, and these are women with normal bladder capacity. I'm not sure this would be lovely on somebody with mixed urinary incontinence, but we don't know. It's still really preliminary and what I would put down in the realm of experimental. But now let's shift gears, okay? And I don't know, I just keep chatting away here about overactive bladder. So overactive bladder, the urgency, urge incontinence, frequency, nocturia, those women. Traditionally, we always think about it as behavioral therapy, conservative management, and medications. That's where we go. Well, does surgery have anything to offer? Well, let's change focus a little bit and talk about overactive bladder. So there's two things about bladders you need to know. One is they have a detrusor muscle. So there's a muscle. It's a muscle, right? So if we can affect the muscle, that would be lovely. And the nervous system is what will drive muscles. You don't have a nervous system, you have no muscle activity. So if we can somehow affect either the detrusor muscle or the nervous system, we can impact overactive bladder. So what do we have? Again, we're back to Botox. What you do to your face, you do to your bottom. Botulinum toxin. So Botox works by affecting, it stops acetylcholine release from the end plates of nerves. Acetylcholine is a primary transmitter to make muscles contract. So if we block that, the muscle can't contract. Well, if you've got an overactive bladder and you're doing this all day long, yay, that's what you want. Now, you don't want to put so much Botox that you paralyze everything and it's just sitting like this and you can't pee. And so that's going to be one of the things. So we used to start off with 200 units. Most people are using about 100 units, and I certainly will titrate up. And what do? It's easy. The woman comes in, mix the Botox. This could actually be done potentially in the office, and a lot of people do it, or in a cysto suite. We put in the cystoscope with a needle,
and we just go poking around, injecting it in the bladder, off we go. And I tell the residents, a little bit like playing video games, right? Go, 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 off we go. And we do it, usually 20 positions is traditional in the bladder. And we've always avoided the bladder trigone. So the area, that triangular area between the ureteric orifices and the opening, the UV junction. And we did that because we didn't want to get reflux. We were afraid if we got that area, maybe urine would go up to the kidneys, and that's never good. But what they're finding is that that's not actually happening. So the beauty of it is that it can be done as an outpatient in an outpatient clinic. That's quite lovely. It needs to be repeated, though. Botox doesn't hang around. As you know, if you've ever had your face done, you need to go back and get touched up. So it does wear off. Does it completely wear off? That's one question that hasn't been answered yet. But usually we'll need to repeat it every 3 to 6 months. And the problem is I try and titrate women and push them out more and more. And I sometimes have a lot of difficulty to get them beyond 3 months. So if you're going to be coming every 3 months, again, we're accumulating a lot of patients coming in for Botox. So what are the risks? Urinary tract infection rates are running at about 25%, so they're definitely not unheard of. And that could be related to the next risk, which is urinary retention. If you're not emptying your bladder, you're at higher risk of bladder infections. And the retention rate is about 6%, but it's dose dependent. So the higher the dose, the more likely you're going to be in retention. So we start off slow, see how women do, and titrate up as we need with the Botox. Now, the other complication we've had in Calgary on a couple of our patients is bleeding. Now, not bleeding so they're hemorrhaging and need a transfusion, but bleeding so they cause a clot in the bladder, and that's like a stone that's sitting there, and then we've caused them retention because of it, and we've had to go back and take out the clot. And interestingly, I couldn't find that in the literature. And so I think it's because people don't tend to report that. But really what you're seeing is the risks are relatively small and they're relatively minor. If a woman has a problem with retention, the problem is it's going to take 3 months for it to wear off. So we've, let's say, had one lady recently, I'd hate to say it was a patient of mine, and who didn't want to learn how to self-catheterize. So we had her with an indwelling catheter, and we'd bring her back about monthly and try and see if she could pee. And by 2.5 months, finally we could take the catheter out and she could void spontaneously. So that is one of the things we need to look out for. And by the way, when that happens, we don't repeat the Botox, in case you were wondering. So what are the results of botulinum? Well, they're actually very good for when we talk overactive bladder. So we have to shift gears a little bit. We do very poorly in overactive bladder, and if you're really skeptical about the results, really start to look at numbers, and you'd be astounded by what we do and why women are happy. I'm not always sure. But when they looked at Botox versus placebo, 29% were dry completely versus 8%. That's actually very good for overactive bladder results. Usually we never get 30% dry rates, even with any medication or anything we do. Quality of life increased or improved by 62% versus only 28% by placebo. These are big jumps. Decreased number of voids per day, 1.6 versus 0.9. Doesn't sound brilliant, but I'd hate to tell you, that's almost better than when we do with medications, and we don't want to admit it. Same with incontinence episodes, dropped very much better than placebo. But what's interesting is 61% of people will stop treatment by 36 months. Now this is interesting, but what is our continuation rate for medications for OAB? Well, they're worse at 1 year. So, in fact, in some ways this is good, but what happens to these poor people after 36 months? It's not like their OAB just magically cures. It doesn't happen. And we're going to talk a little bit about this. So here's where I'm going experimental. So now the thought process is, we've got Botox, which is working really quite well for OAB by our definitions of how we do well in OAB. But women are coming back all the time, and women are dropping out. Can we do better with the same kind of idea? So people with chronic pain, we do nerve ablations. So they come in, and usually it's radiofrequency nerve ablations in their backs or wherever they seem to have neuropathic pain. And they do very well, sometimes up to a year before the nerve regenerates. So we essentially destroy the nerve, and it takes about a year for peripheral nerve to regenerate. Now, what if we did the same thing in the bladder? Neat. And where are these nerves in the bladder? So we talk about the whole bladder and it's a muscle and it's completely innervated, but it's not like these nerves are dropping into the top of the bladder from nowhere, right? It's not like a web, if you want to say, coming in from who knows where. The way the nerves to the bladder come is they come laterally along the side wall. They go through the cardinal ligament, so right at the base of the uterus, and then come out anteriorly, if you want to say, almost around the cervix, and then go to the bladder trigone mainly, and fan out from there. That's how they have to travel. So the bladder trigone now becomes really quite interesting, doesn't it? High amount of nerves in that area. So what if we ablate there? Yay. So this is an experimental therapy, and we're certainly involved in Calgary with the preliminary studies of this, at looking at, let's ablate the trigone and see, can we have similar results? But now, theoretically, we should have longer acting results. They may last for a year with a procedure which is essentially just as invasive as Botox, which is really not that invasive. So potentially could be done in an office setting. That's kind of exciting, isn't it? More to come on that, whether we'll ever see it come or not. But I think this is new and interesting what's going on. But let's go with a truer tried, sacral neuromodulation. Now, sacral neuromodulation's been around in Canada since 1994. It's not new, okay? What's the beauty of sacral neuromodulation is, now let's think about overactive bladder slightly differently. So let's think of neuroactive bladder as, I like to tell women that when they need to pee, it's very complicated. Remember, you learned how to walk before you were toilet trained. Therefore, urination is quite a complex set of neurological steps that need to be achieved for you to be dry. And any glip in that step is going to give you some kind of incontinence, whether it's urinary retention, overactive bladder. So now think more avoiding, okay, in the act of urinating. Think of that next time you're on break and going to the bathroom, just how complicated this is. Think of it as a step of reflexes that are on and off. And there's multiple steps. And each step has to be done at the right time and in the right order. Miss a step, you've got a problem. Miss the timing, you've got a problem. You've got likely overactive bladder, but you could also have urinary retention. Now, what if we can, because you have an intact neurological system, so this is idiopathic overactive bladder, what if we can realign you? Let's go fix you and make that. Let's become electricians and fix the circuitry. Can we do that? Now, that sounds really kind of complex, and we can do that actually with sacral neuromodulation. So how I explain it to women, that makes sense to me because it's complicated. We always thought that what we do is we're sending electrical impulses with neuromodulation and electricity down to the bladder, and because of that making it function. But no, that's not the way it works. We're actually sending the impulses up to the spinal cord and to the brain and allowing messaging to happen. So what I tell women with sacral neuromodulators, it's a little bit like you're trying to read a book, and outside there's some guy with a jackhammer, and he's just going. And you can't focus on your book because there's just too much noise. Well, what do? Well, one, I guess you could leave, but no, you're not going to do that. What you're going to do is you're going to turn on the radio, or you're going to put on music. And all of a sudden, that music allows you to read your book. Sacral neuromodulation is that music. And let's think of it as a soft, gentle lullaby. Okay? And that's how it works. So it allows the messaging to get to the brain, to be processed properly, to come back, to allow normal voiding. That's kind of exciting in a way to be able to do that. The beauty as well of neuromodulation is it's a two-step procedure. We have a testing phase where what we do is we bring women right in our clinic and we put peripheral leads down the S3 foramina to allow next to the S3 nerve root, which is really the main function of the pudendal nerve, that will then go down to innervate not only your pelvic floor, but also a lot to the bladder. Now, S2 is mainly bladder, but there's a problem with our nervous system, and it's that it also seems that S2 innervates our feet. Okay, so we can, when we do the testing, if we're in S2, we see the feet going. Okay, if we're in S3, sometimes we see the big toe going, but the big toe is okay. Now, sometimes I think, well, maybe it's good for the feet, that way you can get to the bathroom quicker, but really that's not appropriate. Okay, because we can't have that foot motion going because that's a complication. So that's why we go to S3. And then we tend to implant in S4 if women have defecatory problems, or males as well. So we test them for 1 week and we see, how are you doing? What we're looking for is 50% improvement in symptoms, and then you're considered, do you want to go on to full implantation? So remember that 50% is the cutoff for us to say, yes, this technology worked. And if you then get 50% improvement, we go to full implantation. So with full implantation, what we do, and I've got one of the batteries here, we put in a battery, and this is for a dual lead, one of the Prime Advance, and we stick it in the back. So it's sitting right over in the buttock area, which is lovely for women, because usually we have enough fat there that it's actually kind of well hidden, but skinny women don't like it there, but that's where we put it. And then we're going to put the leads that are going to come out through the S3 foramina, and we can put it either on one side or both sides, and we're able to then program the battery on different frequencies, different amplitudes, and different cycling programs to try and make people drive for working for them. So what are our results? Well, you've got to recognize when I give you these results, is sacral neuromodulation is not considered first-line therapy. So we're taking people who failed first-line therapy and now bringing them to sacral neuromodulation. What do we find? That 68% of people will pass the testing phase. So recognize that over 30% fail. Okay, so then we don't even consider them. Of those people who have 50% improvement, if we go on to full implantation, 92% will be successful, with success being defined as greater than 50% improvement of symptoms. So those are pretty good odds in terms of being able to see who's going to do well before we bring them to full surgery. And urge incontinence, people talk about 78% of women being dry, which I think is a very high rate considering Botox got you at, 29%. Now what's interesting is, remember I talked about those 36% of people go to Botox, stop after 36 months, where do they go? 70% of those were successful with sacral nerve stimulator. Exciting results, if you ask me. At 5 years, so what are the long term? At 5 years, what do we find? Urge incontinence, still essentially 50% improvement. Urge and frequency improve significantly for what women describe. So 68%, if you want to say cure by 50% improvement, 68% of women by urge incontinence, 56% with urgency are considered by definition cured at 5 years. Those are really good success rates. So what are the complications? Well, with the test phase in a meta-analysis, they reported 0. And probably what it is it's painful to have it done at the time you're having it done, but long-term, no complications, no infections, no nerve injuries that you get from a test phase. In permanent implantation, though, you do get a 24% complication rate. Okay, the most common being lead migration, which is a real bummer because it doesn't work, and pain. Okay, usually at the battery site. And these batteries do need to be changed every 6 to 8 years. Urinary retention, cool. Okay, so we don't have many options for urinary retention. You can catheterize, or you can go to sacral neuromodulation. Isn't this interesting? The same technology at different ends of the spectrum. What's beautiful is because it modulates, you can't cross over. I cannot put a woman with an overactive bladder into urinary retention, and I cannot make a woman in urinary retention an overactive bladder with sacral neuromodulation. Success rates with permanent implant following a testing phase, again, 73%. And 71% still successful at 5 years. So we're seeing long-term outcomes that appear to be continuous. So this is really quite well. But notice, some of them are still catheterizing, right? 5.3 to 1.9, but our cutoff was 50% improvement. So what we're seeing is that that is being maintained 5 years out. So, in summary, I have just talked a lot, and we've covered a huge ground, okay? And each one of these things I've talked about could be a 1-hour lecture in of itself. So when we talked about stress incontinence, we talked about TVTs, we talked about TOTs, we talked about mini slings, we talked about Birch retropubic urethropexies, pubovaginal slings, we talked about bulking agents, we talked briefly about lasers, and we need to be watching what's going to happen to them, and the balloon, because that was really kind of fun and interesting about what's going to go there. For overactive bladder, we talked about botulinum. We talked a bit about radiofrequency and something maybe to look out for in the future for women. And we talked about sacral neuromodulation. And urinary retention, really only sacral neuromodulation. I didn't talk about urinary diversion or bladder augmentation. To me, that's kind of a way out. That's like changing rooms, right? And I thought that was not really appropriate. So, listen, I'd like to thank you for your attention. I hope I've shed a little bit of light in the surgical field and what's out there and what's available, and a little bit of an idea of what some of these outcomes are and what we could be looking forward to. And if you have any questions, I'd be more than happy to answer them, or try to. Thank you. So tibial nerve stimulation to me is not a surgery. It's a procedure you do in the office. So it really depends, I find, with tibial nerve stimulation, and I'm going to be just a little bit skeptical on it. It looks great, right? It's not covered, so you have to pay for it. And the outcomes look really interesting. However, I can tell you personally, I've had dismal results. Now, maybe it's because of the people I send for stimulation. And it's an ongoing process as well. So it's not like you do something and you can walk away. You get it done through about your 6 weeks. And then after that, you need to keep going back. Now, I find it difficult to think, and this is where I have struggled with it, that a sacral nerve stimulator has to be on all the time. When you turn off a stimulator, you're back to overactive bladder. With tibial nerve stimulation, you go once a week for 6 weeks, and then you need to come back every 3 months, and you're going to get a good outcome. And so I'm skeptical with the studies that report great outcomes. Certainly, I've not seen them personally. And so it's tricky. And again, what we're seeing with the tibial nerve stimulation is women drop out. They're not going to keep coming back and back and back all the time. So I think it's interesting. We've thought about it in our clinic, and my feeling was that we didn't have the evidence that we needed to do it. We do have somebody out in Calgary in private practice doing it. I can tell you all the patients I've done personally have failed. And I don't know if that's the experience other people have had. So I'm going to be pessimistic. I don't like to give people hear what you want to hear, and you got to be very careful that they hear everything else. When we actually look at the studies, essentially, and I just remember, I like crude numbers because I can't remember anything. 20% of women will improve overactive bladder symptoms with a TVT, which is interesting because we see the same number with pessaries, right? 20% will get worse is sort of what I quote. And 20% really, and the rest won't change. But I don't like to tell women that their symptoms may improve with surgery, because they're going to only hear that, and they're not going to hear that they may get worse. And if they get worse, they're going to be super miserable. So I will not operate on a woman just for overactive bladder symptoms. Now, the order we do surgery or medical management with people with overactive bladder, traditionally with mixed urinary incontinence, traditionally we've always tried to peg the overactive bladder first and then go to the stress incontinence, knowing though that at surgery a certain number of women will be much better. But the problem with surgery is there's no going back, right? And so I would rather treat the overactive bladder first, because sometimes the stress incontinence doesn't become that important. And people have kept trying to look at this mixed urinary incontinence in the order we do things. And if women present first with stress incontinence and then overactive bladder, they're better off going to surgery, then treating the overactive bladder. And people, this is going back and forth. But I think it's a little bit, in my mind, it's always about do no harm. And if I'm going to make somebody's overactive bladder worse by operating on them, they need to be aware of that. If I make them better, they think I'm great. So I'm not going to tell them that at that point. So that's what I tend to do. I don't want to promise something I can't deliver.
Thank you.